Welcome everybody to today's presentation. Joining me here is Dr. Kathy Balsam and also one of our a pharmacy students, sorry, so you say nursing, Sonali is joining as well, so she may help and participate in the question and answer period. So I'm going to do a little bit of an introduction of Dr. Balsam. Kathy graduated from London School of Pharmacy in 2011 with her Bachelor of Science in Pharmacy and has worked in community practice while she completed her Doctorate of Pharmacy through the University of Florida. In 2016, she's held a variety of different roles in community practice, from relief work to manager, pharmacist in charge, and she has maintained her work in community practice since coming to work for the School of Pharmacy. In 2015, she took on the role of Director of the PharmD program for working professionals, responsible for the development of the program, and now she works as a full-time clinical pharmacist at the Medication Therapy Services Clinic. So you did a little bit of work.
Yeah.
She has had the opportunity to work with nurse practitioners in Fairyland through a clinic outreach project in the summer of 2016 and with many others through medical relief trips to Haiti with Team Broken Earth. So we are so happy that you could come present today. So I will pass it over to Kathy now, who will speak on the Medication Therapy Services Clinic and increasing patient reach in Newfoundland and Labrador. Thank you very much.
All right, thank you. So thanks everybody for having us. We are from the Medication Therapy Services Clinic, like Pam said, and basically we often are also referred to as the MTS Clinic. So we are one and the same, in case you're wondering. And I'm very, very happy to be here, like the title says, to increase the patient reach here in this province. This is a different kind of role for pharmacists, so we wanted to let you know that we are out there and we are available for you. So the way the clinic works, it looks just like, your primary care office and your primary care physician's office, in that, we have clinic rooms, there's a waiting room, just looks just like that kind of a clinic environment. And we offer one-on-one appointment-based pharmacist consultations in this private clinic environment. So our clinic is located at 75 Tiffany Court. It's near the Tiffany Village Retirement Home, if you're familiar with that area here in St. John's. That being said, we do offer distance delivery consults as well. So the patients certainly do not have to be here in St. John's. We'll certainly work with them to figure out the best way to reach them. So we collaborate with primary healthcare providers and community pharmacists to provide optimal care for patients with complex drug-related needs. So I'm sure you guys see a lot of clients out there with complex drug-related needs, or just, complex drug regimens that you may want to have another look at, and we are certainly there for you. So right now it's a free service to the patients. So the way that the clinic operates is that we are funded through Memorial University School of Pharmacy, and of course this allows us to see clients at no charge. So we are evaluating everything that we do at the clinic, and through this we are looking to come up with a way in order to maintain it and keep it sustainable. So in order to do that, we've got to see lots and lots of patients and see exactly what the outcomes are. So right now, and I foresee it being the same way for the next couple of years, is that there will be no charge at all to the client. So this is our team. Dr. Debbie Kelly is our clinic director, and then you can see me there as well. And I'm the full-time clinic pharmacist, so this is my full-time job, Monday to Friday. The other clinical pharmacists are also faculty members with the School of Pharmacy, so they operate on a rotating basis. So they're teaching, and then 4 days a week, and then 1 day a week they work in the clinic. So we're going to have 2 pharmacists there on any given day, and we all have a variety of different interests in terms of our research background and stuff like that. So certainly any topic area is more than welcome. So the background for the clinic itself, we are based on 3 different pillars, and this is kind of supporting our reason for being. So one, and I guess the biggest service that we're here today to promote, is the medication management service. So this is those comprehensive and focused medication therapy assessments, and then we go forward and bring any recommendations to the primary healthcare team. Another thing that we're really involved in is different research initiatives. So we are hoping to be seen as an incubation center for pharmacy research. So like I said, through our consultations, we're evaluating everything we're doing to see if there's any what health outcomes come of it. But we're also involved in a variety of different things. I'm leading a deprescribing project with St. Pat's Mercy Home, which is quite interesting. So doing some deprescribing there in the seniors population. We're also looking at a research project that involves patients when they get out of hospital, so in that transition from hospital to home, and seeing, you know, what difference we can make in those kinds of situations. And we're also doing a smoking cessation program. So we do have a quite intense free smoking cessation program that allows patients to meet with us, and as pharmacists now in Newfoundland, we can prescribe for smoking cessation agents. So we kind of tailor our approach to the individual and offer both the pharmacotherapy and a very intensive counseling program as well. So just some examples. And then, of course, teaching and learning. The pharmacy profession is growing, and we are changing our curriculum. So as of 2020, every pharmacist graduate in the country will have to be PharmD, which means they're trained longer and more extensively in a clinical environment. So as part of our mandate, of course, for teaching and learning, we wanted to give the students a place to be able to come and see patients in a more clinical setting. So teaching and learning is our other pillar. But again, primarily I'm here today to talk about the medication management service. So this is what we provide, basically anything and everything to do with medication. So we can see patients on a comprehensive medication therapy assessment basis. So sometimes we get referrals from different people working with clients out in the community, be it nurses, OT, PT, anyone that sees someone that says, you know what, there's a lot going on here. Maybe someone should have another look. I wonder if they need all of these medications, their blood pressure is still not controlled, or they're we have a lot of patients more recently with uncontrolled depression, all sorts of things. So just a comprehensive medication therapy assessment allows us to look at absolutely everything that's going on for the patient. I should also mention that we have access to ARNNL and Meditech, so we're able to go back and make sure, you know, we are in the know about what's going on, especially when people are transitioning through different modes of care. We can also provide chronic disease management support. One of those programs, of course, is our smoking cessation program, but we do, you know, provide chronic disease management in terms of diabetes, hypertension, COPD, whatever it may be. Another big thing that we do is provide options to simplify complex medication regimens. So we know that patients out there are often taking a lot of different medications at different times throughout the day. And if people are really struggling with remembering to take their medications, we always try to find options that may be simplified. So, you know, if they're taking something 4 times a day, we can get them transferred to something twice a day if available, things like that. Always recommending medications that come in combination forms already, those sorts of things. We also provide adverse effect and drug interaction management. So a lot of the times when there are multiple medications on board, there can be significant risk for adverse effects, drug interactions, that sort of thing. And then sometimes it comes down to, okay, we know the drug interaction is there, but how do we deal with that? And what can we do to make it safer? Also, sometimes we see patients, a more recent referral I had was a physician who had referred a client to us after finally getting their hypertension under control with 4 different drugs, but then they developed this rash and they weren't quite sure. They had never seen those drugs be associated with this rash before, but kind of wondering if it's because of the drugs and what do we do. And then also this medication adherence supports and education. So I think a lot of the times the patients come in and we do sit down with them for an hour, and oftentimes it's much longer than an hour. But a lot of the times the patients have a lot of questions. So they may be referred by any healthcare professional, but then when they get there, they have a lot of questions themselves. So I think the biggest thing is that they do feel like they know more about why they're taking things and how to take things and all that sort of thing. Not much different than what the community pharmacists are offering, but of course with much more time set aside to do these things. So there's a lot of people who can benefit, particularly people who are in hospital recently. We know, as I'm sure you guys are very aware, that when you're in hospital, there's a lot of changes made to medications, and then oftentimes the patient may not know exactly what the plan is for when they get home. We see this all the time, patients that were taking something before hospital, they get out and it was switched, but they accidentally take both because they didn't quite understand what was going on. There's a wide variety of things that can happen once people get discharged. So we're very happy to sit down with people, especially if they've got a new diagnosis and new medications on board. Also, people who have multiple or challenging medical conditions, which is a lot of people. So oftentimes there's not just one kind of medical condition on board, it's a lot at play. So certainly these people can benefit. Also, people who take multiple medications and have a complex medication regimen. It can get quite complicated out there. And sometimes people are having side effects and then other medications just get added. We try to determine the cause and figure out if we can change that offending medication instead of just keeping adding more. People are often having trouble with their medications, like side effects, and then people also have trouble remembering to take their medications as they should and have different adherence challenges as well. So we definitely see a variety of drug-related concerns. So these are just some examples. Sonali and I had a patient more recently with some uncontrolled depression, and she had a kind of a wish list in terms of what she wanted. She wanted medication that didn't cause weight gain, but would keep her up throughout the day. And the physician kind of have tried everything. So we were there kind of tasked with the idea of coming up with something that would suit the patient. I had another patient last week that had some significant cognitive decline over the last couple of weeks. And when we looked, actually 4 out of 5 of her medications could be contributing to this. So we certainly work with the physician to taper everything down slowly but surely, and making sure that we kind of do things according to plan to try to take away those medications that the physician didn't quite realize were even implicated with cognitive decline. We see patients for hypertension, asthma, COPD, GI issues, sometimes, especially with newly diagnosed diabetes, when they get put on metformin, if the dose is escalated too quickly, we know all about those GI side effects. So really, counseling patients on that and helping them deal with those. Renal impairment is a big thing that a lot of prescribers aren't too familiar with and how it affects medications. A lot of medications are either cleared through the liver or kidney or both. So when you've got a patient that all of a sudden now has liver dysfunction or renal impairment, it's important to look at their medications to make sure everything's safe. If not, of course, they can accumulate and cause more side effects. So we certainly are brought in at that time as well. So we are really excited to get to talk to you guys here today because we've been trying to expand our reach. When we first opened in March of 2015, we were open to physician referrals only. So patients couldn't self-refer and they had to be referred by their physician. This is because, of course, we know that they handle most of the prescribing, if not all, for most clients. So anytime a medication has to be altered, as a pharmacist, I'm not able to do a lot of those dose titrations and changing medications and things. So everything has to be brought back to the physician. So basically, we're recommending changes to medications that have to go back through the physician. So when we first opened, it was only physician referral. It was hard for us to get going. Physicians are a harder group to engage. So, and of course, this is quite a different service than people are used to seeing pharmacists as. So we were struggling, but more recently we opened it up. So people can actually self-refer simply by calling and booking in. And that has certainly kind of opened the gates in the sense that a lot of people that I think that may not have gotten access before have now gotten access. And some of those patients just have specific questions, but some say, what am I taking all of this for? What is all this for? Things have changed recently and I want to know more about it. And we are also really encouraging any healthcare professional, including nurses, of course, to refer. And we appreciate the fact that you are everywhere. So in rural communities, oftentimes there's nurse practitioners out there, and I got the great experience of working with a variety of nurse practitioners out in Fairyland. And, you really are the primary care providers out in these areas. That being said, of course, the hospital is a big place. Community health, we did some presentations recently with community support. And a lot of the audience were telling us that there's quite a lot of people out there that are on a lot of medications and really struggling in the community. So, we just said refer. Certainly, even if nothing's being changed, education can be provided for everybody. And of course, an emergency as well. And we've been starting to get a few referrals from the emergency department when patients are showing up at emergency with a drug-related concern. Maybe they overdose on a medication by accident, or, you know, maybe their medications just aren't controlling their diabetes and they end up in there with hypoglycemia, whatever it may be. We're certainly getting referrals from that department now as well, which is encouraging. But I want you to kind of think of if there's any particular clients or places that you wonder if we kind of fit in. Certainly, I'd love to hear where you think we can work with you. And like I said, it is a free service, and we will be able to see patients that live outside of the overpass, as they say, as we are now doing those distant consults as well. So this is our process, just to kind of give you an overview. When patients are referred, like I said, it can either be self-referral or any healthcare professional can refer, and then the patient is contacted to book the appointment, and at that point we get their consent to access their medical records. Then we do a chart review. So the pharmacist will then go through Meditech, ARNNL, and any other records like pharmacy records, et cetera, and we'll access the patient's medical history, lab work, as well as prescriptions, so we get a good idea of what's going on. And then at the appointment, it is a one-on-one visit. It's about an hour long, oftentimes more than that. And we can discuss everything from their lifestyle factors as they affect their medications, medical conditions, medications, and a comprehensive review of systems is completed. After this, the pharmacist provides an up-to-date medication list. As we know, oftentimes the medication list isn't exactly how the patient is taking it when they go home. So we get an up-to-date medication list, and then we provide all of our recommendations and suggested management strategies. So we, do our due diligence in terms of referencing when appropriate, and oftentimes we see weird and wonderful things at the clinic. We had a lady just last week that had burning mouth syndrome, which has significantly impacted her quality of life, and the physician wasn't quite sure, what's the best treatment for this patient. She's had a lot of other medical conditions too, quite a rare condition, so was referred to us and that sort of thing. So we certainly go back through all of the research that we can, and then the plan is communicated with the patient. We call the patient, let them know exactly what we're recommending, and we often provide them with a copy of the letter. And then we'll send a copy of the letter to the referring healthcare provider. So if you are working with a client in community care or wherever it may be, and you send a patient to us, we will certainly be happy to send you back our letter so that you know kind of where we went. And then, of course, it's got to go back to the prescriber to make any changes. And then we do wait for a response. Like I said, we are evaluating everything we do at the clinic. So with our letter, we do ask the physician to get back to us and let us know if they did go through with our plan or if they accept or decline our recommendation, and leave a space there for comments. And we really, really appreciate this response, because then we know, of course, what follow-up is required. We'll see patients back as much as needed. Sometimes we're brought in to help with hypertension, provide education and teach patients how to use their blood pressure cuffs at home, all that sort of thing, and we can follow up as much as the referring healthcare provider wants us to be involved. So I think it is really important that everyone is on the same page, and we really do value that response. So like I said before, we can certainly be referred to for comprehensive medication assessments, but there are certain clinic programs that are becoming pretty popular. We here at the MTS Clinic are partnered with the Canadian Deprescribing Network, and we have all gotten training in deprescribing. So we've found that deprescribing is a new big thing, and it's going to get bigger over the next couple of years as patients become more aware of the issues of taking certain medications for too long. We put a lot of effort in when patients are prescribed medications to do the upfront monitoring and making sure, but we don't really talk to them about when they should be coming off of these medications and when they may no longer be beneficial. So as you know, there are a lot of seniors in this province taking a lot of medication. So 30% of our seniors are taking 5 or more. And actually, I believe it's 25% of seniors are actually taking 10 or more. So there are quite a lot out there. And this is why we were brought into the St. Pat's Mercy Home, like I mentioned earlier. They had a high rate of prescription drug use, and they asked us for help in this regard. And we've been in there, and I can tell you just preliminary results on one floor at the home. We've taken away on average 2 to 3 meds per resident successfully, and quite well. And they went from an average of 14 medications down to around 11. So this can be done. It's going to be a new kind of up and coming buzzword, I'm sure. But it is important, and as you guys, I'm sure, know the dangers of maintaining prescriptions for too long, The Canadian Institute of Health Information, or CIHI, have identified certain groups that they are targeting right away. So they've identified as sleeping pills, certain stomach pills, certain diabetes medications, and antipsychotics are common drugs that are used longer than required and could be beneficial to deprescribe. And we also know that 1 in 5 drugs used in older people may be inappropriate. And this is often in cases where they were once appropriate, and then over time, their benefit certainly isn't as much as the risk. So, of course, we're not going to be targeting taking away life-saving medications, but we focus on identifying duplicate, unnecessary, and potentially harmful medications. Because as we know, as people age, medications do change, and the body changes the way it handles medications. So oftentimes, a drug can lose effectiveness and stop providing that relief they once did. And we all know about the prescribing cascade. For example, if someone goes on an opiate and then they get constipation, they get put on, a laxative, and it can go on and on and on. So we like to kind of evaluate the whole plan and figure out exactly what was causing that, and if those medications were just put on for symptom relief and just maintained for so long, or what exactly is the story here. So there are medications, like I mentioned, that we are targeting. So if you see patients that are on these, this is the ones that the Canadian Deprescribing Network has well-referenced algorithms for the deprescribing and well-known evidence on why it's not a good idea to take them long-term. One that might be surprising is this first topic, those proton pump inhibitors. So these are things like robeprazole, omeprazole, your Periops, your Lasix, your Nexium. So they're often started in hospital for stress ulcer prophylaxis and should be discontinued upon discharge, and they're not often, successfully discontinued, or, it gets missed, or the patient's not quite sure and just goes on and takes them at home anyways, those sorts of things. And I mean, even in community, if a patient is prescribed it, it should only be used for 10 to 12 weeks maximum if a patient comes in to clinic with, reflux, GERD, that sort of thing. Now, there are some reasons for continuing them long-term, but it's usually like Barrett's esophagitis, and these things would require diagnosis with a scope and that sort of thing. But the majority of people that are out there on them long-term really don't need them for that long, and there are risks associated. So they do increase your risk of C. diff infections and diarrhea. They interfere with the absorption of various medications and nutrients from food, like B12 and also magnesium. So we've seen a lot of people come in with hypomagnesemia, and it's most likely attributed to the long-term use of the PPI. And this is also important because, as you know, a lot of medications may need an acidic environment in order to be absorbed, and these medications are decreasing that acidity. So sometimes a patient could be taking, a variety of prescription medications along with a PPI, and they may not actually get the benefit from those drugs because they're not being absorbed. Same thing with food. So people can have like a very nutritious diet, but they may not be absorbing the B12 from their food or the magnesium from their food because they're on these drugs. There's a potential link to kidney disease that was kind of recently found in the last couple of years, and there's certainly an increased risk of fracture, and which, of course, we see as an issue in our elderly, and it increases the risk of community-acquired pneumonia. So all kinds of things, and there are often drugs that are easily deprescribed. The biggest thing is to not stop them abruptly. If you stop them abruptly, your stomach can have this hypersecretion of acid to kind of make up for the years of being on them. So that's often a reason why people stop and then start them again, but we just recommend a slow taper, and we develop a schedule of deprescribing. We all know about sedating medications like the benzos and the Z drugs. So this would be your Zapopone and the new Sublinox brand name. So of course, these can cause dependence, and especially in our elderly and our aging population, an increased risk of falls. We also see a fair bit of confusion in daytime sedation, and people can be on, benzos for years and not really have this confusion and cognitive dysfunction. But as we age, it affects it. Our bodies don't metabolize it like it once did. These often go through the liver, and if the liver isn't what it once was, they're accumulating, and there's much more risk of side effects. There's also a big push nationally to get rid of glyburide. So glyburide is a common diabetes medication, but as you know, there are quite a variety of medications out there for diabetes now, and glyburide just has such a high risk of hypoglycemia that it really shouldn't be used anymore. So we're working with patients to kind of get them switched over to something that would be just as beneficial in terms of glucose control, but without causing that hypoglycemia. And obviously, the more medications the patient is on, the higher the risk of side effects and drug interactions. So it always doesn't hurt to have another look. Our patients have really loved it so far. This is just an example of a client that I saw more recently. He felt that he was taking too many pills, and the physician said, okay, yeah, I probably agree with you, but I don't have the time to go back and look through everything and have a look at what you're taking and why. So if you want to just go to the clinic, feel free. And we helped him get off 3 medications that he no longer needs. So there's a lot of different people that can benefit from, just the deprescribing things. And I'm not saying that we always take away medications. Oftentimes we're looking to add medications that may be of benefit too. But people are really loving the service. And the cost of it, of course, being free at this point helps us, remove that barrier as well. So we've been able to see a lot of patients. Another thing that we do is falls assessment. So, of course, there are harmful effects of medications that can cause an increased risk of falls. And as you guys are probably aware of as well, 20% of people over the age of 65 who live at home fall each year. 20 to 30% of those who fall suffer moderate to severe injuries, making it hard to get around or live independently. And we know that if someone falls, it can be detrimental. So we really have a look at medication. And if there is a patient who has been falling recently, it would never hurt to have another look at the medications and see kind of what medications may be playing into this. Some of the drugs that we look for when we're doing a falls assessment are those that can reduce mental alertness, affect the balance and gait, and cause drops in systolic blood pressure while standing. Obviously, mixing certain medications can increase this effect. So we do prevent falls by working with the patient and their care providers to monitor medications and assess interactions. Another big thing is the cognitive dysfunction screening. So like I mentioned, there are a lot of medications that can cause cognitive dysfunction, and it may be things that people have been on for a really, really long time. More recently, I had a client who was on alprazolam, high-dose trimipramine, and Fiorinol combination for 40 years. And then all of a sudden, when she started having cognitive decline, we started taking them away. And when we took them away successfully, without aggravating some underlying conditions, she was able to realize that their medications were certainly contributing. And oftentimes you can get confusion, but you can also get delirium, and it may even mimic dementia. So it is important to just have a look at the medication. So we know that medications like opioids and benzos can do it, but also anticholinergic. So a lot of these are, your urinary incontinence medications, and it also includes some over-the-counter medications like your Benadryl and your Gravol, which patients may be taking that you may be unaware of as well. And oftentimes the memory impairment associated with medications can be reversed when stopped. So we do hear these anecdotal stories of medications being stopped and patients, bouncing right back, and it's quite encouraging. So we do certainly take this seriously. So we are looking forward to expanding our reach with your support. We're really, really happy to kind of come in and let you know about this resource and let you know that we're here and available for you. Here is our website and our phone number. And that looks like the end. I will apologize because there was one slide that I added late. It looks like it didn't quite make it, but I do want to let you also know about our Drug Information Center. So within the university, we have a DI call line, so a drug information line that you can call. So this is if you have any quick questions about a medication. So if you had a complex patient that you wanted the patient to be seen, by all means send them to the clinic. If you have a question that you're just wondering about, or if you saw something that's being used off-label in a patient, and you're wondering, what's the evidence for that, or should I continue that, whatever it may be, you can certainly give our Drug Information Center a call. I believe our Drug Information Pharmacist was going to hopefully call in. So when we unmute the lines, we'll see if he's there, and he can give you the phone number and everything. But I did want to put in that word for the Drug Information Center because it is a quick way to get some answers of any questions that you may have about medications, especially when you're treating a patient and you want a quick answer in your office. That might be something that you could benefit from. So, like I said, we are on Facebook, Twitter, all that stuff, and we do have a website, mtsclinic.ca. Our phone line is there, and our fax line is there as well. If you were interested in referring a patient, of course, the patient can call on their own, but if you wanted to refer on their behalf, we'd be happy to hear from you. And we do have a referral form on our website. So you can go there, and there's a fillable one as well as a print-off one that you can fill in and just fax off, and we'd be very, very happy to work with you.